my name is Katie Brooks. I'm an LCSW, clinical director and founder of Good Therapy San Diego, and a certified EMDR therapist and approved consultant. Today, I want to talk a little bit about flash forward procedure. Flash forward technique is an EMDR therapy. In EMDR therapy, addresses anticipatory anxiety and irrational fears about future catastrophic events. This is done by using the standard EMDR protocol with the client's imagined worst case scenario rather than the past trauma. It's one of my favorite interventions and procedures in EMDR therapy because it's so darn effective. With regular talk therapy or CBT or even exposure, it's really hard to get to and resolve anticipatory anxiety like phobias or fears related to future events because they just haven't happened yet. But with EMDR, it just smashes through that barrier with imaginal exposure and desensitization, targeting the limbic system activation where the fear actually lives in the body and the mind. So I want to talk a little bit about the future as well. There are 3 different aspects and techniques that we use in EMDR in order to process the future. Future fears, flash forward, and future templates. And all 3 of these things are different even though they deal with future events. So future fear situations can be done using the standard protocol, and the future fear is processed as a regular present trigger. And we'll talk a little bit about how that is done. But then a flash forward procedure focuses on processing feared catastrophic scenarios. And then future templates are used to build skills for future challenges. So let me give you an example of a common presenting symptom or a common presenting issue that a client might come in that you can use these skills on. So let's talk about maybe a client that comes in that is suffering from insomnia. Well, you'll want to establish a targeted sequence plan from a flip back. You'll want to get the worst recent experience of it, which might be last night or sometime this week. The negative cognition, it might be I'm not safe. What's the emotion, anxiety, where is it in the body, in the legs? And then you float back to the earliest time that you can remember feeling these same feelings and having these same thoughts. Then as always, you're going to gather the past memories, gather the present triggers, and establish future templates for those present triggers. The future fear is going to be one of the present triggers, right? And that's going to be, I'm afraid that I'm not going to sleep tonight, right? And you would process that just like any other present trigger. Flash forward is different from a feared future situation in that we're dealing with the worst case scenario about the future fear. So in this example, you would ask the client, what's the worst part about not sleeping until there are no new responses? So, for example, what's the worst part about not sleeping tonight? It would increase my anxiety. What's the worst part about that? I wouldn't be as good of a mom the next day. What's the worst part about that? I wouldn't be able to handle it. What's the worst part about that? I would be in pain. What's the worst part about that? I think that's it, right? So that's when you know that pain is the worst case scenario in terms of the future fear, insomnia. So once you've come to the final conclusion, you'll want to target the pain itself, right? Rather than the future fear of insomnia, if you really want to do flash forward, you're going to target that final conclusion. So you can ask your client to pull up an image of the pain after not having slept the night before. What's a negative belief about yourself that goes with that? I'm not good enough. What would you prefer to believe? I'm doing the best you can, and go through your whole thesis. And you can use that as a very specific present trigger target as well. You can also do it as a cognitive interweave as a part of a present trigger processing. So if you're, processing insomnia as the future fear, you'll notice that, and you notice that there's looping or that they're getting stuck, you can then ask right in the middle of processing, what's the worst part about that? And once you get the worst case, you say, go with that rather than ticing it and making it its own target. So to review, you can either get the worst case and target it very specifically on its own, or you can use it as a cognitive interweave. I want to preface that you'll always want to get a targeted sequence plan if you can for any presenting complaint, and you also always want to resource your client. If for some reason somebody comes in with a future fear and they don't really get any past memories from your float back, that's okay. You can start with the present trigger or the future fear, and you can even do flash forward to start. And you might even pick up some past traumas that way. But just make sure that if you're starting with the worst case, if you're starting with flash forward, that you've established a really good relationship with your client, you've taken a good history, and you've resourced them, and they've got some skills, and you know that you can contain them. So why choose flash forward as a cognitive interweave versus a target? So I often will use it as a cognitive interweave first to see if I can resolve without targeting it directly, or if the future fear is an offshoot of the main complaint, right? It's kind of something that came up that's not necessarily what we're working on totally, but it's something that we need to address. I might just do it as a part of regular processing, right? I won't give it its own target. I also like to start with a cognitive interweave in terms of flash forward, because if I can resolve it within the processing itself, it's much more efficient and effective and quick, right? I will often use it as a target if it is actually the main complaint, or it's the cognitive interweave is not necessarily working to resolve it. I might just make it its own target. Another reason why I might make it its own target is if it's part of the main complaint and you can see that this future fear is limiting this person's functioning. So let's just say your client has a speech to do the next day, and they're literally going to not do the speech. They're thinking, I'm just going to flunk this exam. Well, you really want to get serious with that and make it its own target and really try to get to a place of resolve with it so that this client can perform in class the next day. So I personally feel as an EMDR therapist that the wisdom that comes from being a clinician is often observing how it resolves itself in our clients. And I think that's why sometimes flash forward is so scary. Going to the worst case scenario and then not knowing how this client is going to handle imaginal exposure of the worst thing that could ever happen to them is really scary for the clinician if they don't have control over how it's going to resolve itself and they've never done it before. And really that wisdom is gained from experience. You kind of just have to do it to see that it resolves itself within the client. So what I want to do is give you a few examples professionally of how I've seen it resolve, and then also give you a personal experience of how it's resolved within me when I went to go see a therapist for a future fear. Okay. So I'm going to start with a client that was presenting with chest pain. I had a targeted sequence plan for postpartum anxiety with this particular client and was in the middle of reprocessing the chest pain as a present trigger. What I noticed was looping in the reprocessing, and I decided to do flash forward as a cognitive interweave this time. So what I said was, what's the worst part of the chest pain? That I'll be uncomfortable. What's the worst part of that? That I'm not happy. What's the worst part about that? That my life will be harder. What's the worst part about that? That I will never recover. What's the worst part about that? And she said, that's it. And I said, go with that. That you'll never recover. And after her bilateral set, she popped back up and said, even when I say that, that sounds silly. I always recover. And I said, go with that. She said one more positive statement. I moved back to target and the SUD had gone down significantly. So that's an example of a simple cognitive interweave that I used actually just recently with a client. I'm going to move on to another client of mine that had a little bit more of a scary situation in terms of having a future fear of chemo. This particular client has stage 3 ovarian cancer and is in the final stages of treatment. She underwent multiple rounds of chemo and a huge surgery that was very scary, but she recovered from. And we are looking at 2 last chemotherapies, one of them coming up in the next week. And so I decided to target the future fear of chemo. And what I noticed was that she was looping on preparing for the chemo. In order to avoid the what ifs of what was going on, she was saying things like, I'm going to do this, I'm going to do that, and I'm going to do this, and everything's going to be fine. And then I said, go with that. And she said, I'm going to do this, I'm going to do that, and I'm going to do this, and everything's going to be fine. And in my head, I thought, okay, she's stuck, she's looping. And there's avoidance. And anytime there's avoidance in anxiety, it actually increases the anxiety and it doesn't resolve. So even though I got a little countertransference, knowing that the worst case scenario for this one was going to be very scary for her and also for me, I knew that if we didn't go there, that the anxiety would remain. Her SUD level was a 3 at that time, and I could not get it down. We had started at a 10, so just doing it as a future fear, present trigger, had gotten it to about a 3. But I felt like in the next week, the anxiety was going to increase quite a bit if I didn't clear the present triggers. So I went there. I asked, what's the worst what if? When she said, I'm trying to avoid the what ifs. And she said that I have a bad reaction. And I said, what's the worst part about that? And she said, I won't be able to continue this chemo. And I said, what's the worst part about that? The cancer would come back. What's the worst part about that? I would have to do treatment again. What's the worst part about that? It could kill me. What's the worst part about that? It means I wasn't strong enough and I have to face my own mortality. What's the worst part about that? And that was it. So I said, go with that, and did a bilateral set. And when she came back up, she was tearful and couldn't really talk. I said, what's the emotion coming up for you? She said, there's just sadness. And I said, are there words to the sadness? And she said, no. And I said, go with that. When she came back up, she said, I'm not ready for this. I'm not ready for that. And I said, go with that. And she said, I still have will. And I said, go with that. And she said, I'm a fighter. I said, what does that mean about you? Because I knew that I would get a positive statement from that, because she had already said pretty much 2 positive statements at that point. And I thought, oh, we're going to get a positive cognition out of this one. And she said, and she did, I said, what does that mean about you? And she said, I'm strong. And in order to reinforce that, I said, say that again. And I did slow BLS with her in order to resource that positive thought. When she came back up, she looked, the tears had stopped. She looked a little relieved, and I congratulated her for going there. This was the first time that this client had faced her own death, and it took a while for us to have the confidence to go ahead and do that, me as the clinician and her as the client. I said, Did you notice that this was the first time that you opened the curtain to take a look at what could and actually is an option here? And she said yes. And I said, you should be proud of yourself. And she said, I'm extremely proud of myself, and I feel a lot better having done that. And I said, okay, let's go back to Target. So we went back to Target and asked, and there was still fear, but it was a half. The SUD level was a half, and it was in her stomach. I established that the half was ecologically valid in that she said chemo is never going to be positive, right? So we went on to install the positive cognition of I'm fully prepared. She went ahead and installed, the VOC was 7. We cleared the body scan, and she ended the session grounded, stable, and ready for her chemo. It was pretty incredible. And I was extremely proud of this particular client, and I can't wait to see her next. It was pretty recent. Okay, so let's move on to one more. This last one is a woman who is having a future fear of a C-section. This one also has a targeted sequence plan for the presenting complaint of health anxiety. She had a very traumatic birth with her firstborn and had some little t traumas growing up. So I did a full standard protocol treatment plan with her. This session, I was reprocessing the present trigger of the future C-section, the future fear. And the negative belief was my body can't handle it. The positive belief was I can handle it. The emotion was fear, and the SUD was a 7 or an 8. Body sensation was in the stomach. I ended up using Flash Forward as a cognitive interweave this time as well. And the reason why was because she started looping. And she mentioned catastrophic event in the processing. She said, my doctor said catastrophic event, and my anxiety peaked. And I said, what is the worst case catastrophic event? And she said, I'll die. And I said, go with that. At that point, she came up and said that she had come to the conclusion that death was not the worst thing, and that being so sick and not being able to live was actually the worst. And I said, go with that. She said, I would miss my friends and not be able to have fun. And I said, go with that. She came back up and said, wait, no, my family is what matters, and they would never leave me. At that point, she had come up with 2 positive beliefs. I believe I said, go with that. And she said, my family is what matters. And so we went back to Target. When we went back to Target, her SUD was significantly down. It was, I believe, a 1 or a 2. And she said, I hope nothing happens. I said, go with that. And she said, it won't be my fault, but I hope nothing happens, which was in my head a positive, but also with a little bit of avoidance anxiety. So I did a cognitive interweave because I think the next round she said something like, I really do hope nothing happens. And I said, imagine if it did, as a cognitive interweave. And I said, go with that. And then she said, when she came back up, she said, I feel better. I have a team by my side. I have doctors. I have my husband. I have my family, and everybody will be there. And she had 2 positive thoughts after that. And then I went back to Target, and she ended up clearing it. Now, if she had not cleared it as a cognitive interweave, I would have targeted the worst case scenario. So in the next session, I might have gone to, what was it? The worst case scenario was being so sick that she wouldn't be able to live. That would have been the specific target for Flash Forward. But since we cleared it as a cognitive interweave, there was no need to do it as its own target. And at the end, her positive cognition ended up being, I can handle this. And she's prepared. Um, I do have an example of two main targets that one I did on a client and one I did myself. I do have a client that is afraid of getting injections. He's afraid of needles because he has a very traumatic medical past. He is paraplegic and has a lot of medical trauma. So I actually have an RTEP treatment plan for him. This one, though, I did as a future fear because he needed to go get an injection pretty soon, and so I targeted it as a main target because he needed to get the injection very soon, and he has a lot of avoidance in regards to it. I knew he wouldn't go if we didn't really get on top of it. So his worst case scenario was passing out, and so we targeted passing out. Can you pull up an image of passing out? What's the negative belief about yourself? I'm not safe. What would you prefer to believe? I'm okay. And we TIC'd passing out. We were able to reprocess that. We cleared it. After he started saying things like, "It's okay if I pass out. I don't want it to happen, but I'm not unsafe if it does, and I can handle the embarrassment of it. It's just an emotion, and it will pass." The positive cognition at the end that we installed was, "I can handle this." We did a future template of him getting a shot successfully with the positive cognition of, "I can handle this." And then that week, he did actually go get an injection and was very proud of himself, and he did not pass out. So that is my last example of clients that I've had that I've used the flash forward. The last one I want to talk about is an example with myself. There is something magical about not only providing EMDR therapy for somebody, but also feeling it in your own body as a clinician. And if you are a clinician listening to this, I highly recommend getting your own work done. It is an incredible experience. A, it's extremely effective if you're struggling with something, but B, it is invaluable to know what the client is going through on the other side of the couch. So I'm going to give you an example of what happened for me with a future fear. So when the pandemic hit, of course, I am the director and founder of Good Therapy San Diego. It's a group practice in San Diego. We have quite a few clinicians that work for us. And when the pandemic hit, nobody could see their clients in person. And we had to quickly set up a virtual office for, I can't remember how many clinicians we had, but like maybe 15 to 20 at that time. And immediately lost half of our business. I mean, not only was I afraid for my own ability to pay my mortgage and feed my children, and also lose this business that my husband and I had worked so hard on, but also I was very, very scared about my clinicians' ability to care for themselves and pay their mortgages and rents and feed their children and families. So I went to go see my therapist, who is extremely gifted in EMDR and also an approved consultant. Her name is Annie Robert-Shaw. She targeted my future fear of losing my home. That was the worst case scenario for me during that time. And she did it as a main target, not as a cognitive interweave, because my presenting complaint was this intense anxiety related to losing half of our clients when the pandemic hit. So when she asked me to pull up an image of losing my home, it was really interesting. My image was me, my husband, and my children all sitting on the ground where my house was supposed to be, and a tornado had taken my house away. It's pretty interesting, right? And my negative belief was, I'm not safe. And the positive belief I was going for was, I'm capable and I can handle this. The way that it resolved itself in me, I actually remember the shift in perspective in my body. All of a sudden, I realized, oh my gosh, my safety is not reliant on the things around me. My safety is reliant on my internal capabilities and resources, right? My ability, my resilience, my intelligence, my husband and my children, my family is what matters, right? And so but it's not just the realization, that the cognitive realization that happens during flash forward. You feel it in your body, this huge perspective shift of what really matters happens, and the anxiety just goes away. All the material things, all the things that you could lose, it just goes away. And I remember clearing the SUD with the words, I'm capable and we will rebuild. It was an incredible experience, and I want to thank my therapist, Anne, for helping me with that and showing me how effective flash forward can be on the opposite end of the couch. I also want to thank you for listening, and I hope you got a lot out of my video and about flash forward today. Thanks so much.